So good afternoon, everybody, and thank you for joining us today for our live webinar. My name is Susanna Deutsch, and I'll be your host for today. I am the Director of Neurovascular at Viz.ai. And for those of you less familiar with Viz.ai, Viz is the leading AI-powered disease detection and care coordination platform used in more than 1,000 hospitals in the US and EMEA. So today, in our first webinar of the series, we are thrilled to have Dr. Dorothea Altschul from Valley Health System with us today to share how adopting Viz has created more efficient care coordination for her stroke patients and for the care teams. Just a little bit of background on Dr. Altschul. Dr. Altschul is the Director of Neurointerventional Neurosurgery at the Valley Hospital and Neurosurgeons of New Jersey. She is board certified in neurology and vascular neurology, as well as CAS certified in neuroendovascular surgery. So now, without further ado, I'll turn the webinar over to Dr. Altschul.
Thank you, Susanna, for the introduction. I'm really delighted to be here today and to talk to you about our experience with Viz in our healthcare system. This is the community I come from. It's a not-for-profit hospital serving around 440,000 people in 32 towns in Bergen County and the adjoining communities. You can see it's close to New York State. The red marks the hospital, and it's a very population-dense area with multiple other hospitals in the area, including other comprehensive stroke centers that are marked here in teal. So Valley is also a comprehensive stroke center. And this is largely, a journey of how we got there as well. So everyone comes from a different situation. Stroke care is incredibly complex, and there are very different systems of care that everyone comes from. We are a direct hospital. We are not a spoke and hub place. So that is very important to distinguish, since those two places may have different goals of care that they want to accomplish. At the time when we were looking to improve our workflow, we had already been using Rapid for the diffuse study. And we were familiar with such a technology. And we, however, wanted to improve a little bit more on bringing all members of the stroke team together. The CTP was introduced with the Fuse and Dawn study into the stroke community, and it had caused actually a lot of discussions and arguments at that time as to, what the timeframes should be. Should we run it before 6 hours or after 6 hours? What does it really mean? We had to provide a lot of education on CTP in general. This has dramatically improved over the past 2 years. However, at that time, really, we wanted to bring everyone together, improve our process and alignment, because we're also at the same time looking to become a comprehensive stroke center. So again, every hospital system has their sort of challenges, and some of the unique features of I don't want to say community hospital, because I would have to apologize to the Valley Hospital Health System. I would much more describe it as a non-teaching hospital. And if there's anyone who's watching today is coming from a non-teaching hospital, I think they have unique challenges. And there's, resources are difficult. And perhaps allocation to the stroke team can have its challenges. There are no fellows or residents, and actually someone told me from a teaching facility once, well, we don't need Viz because we have fellows and residents. Well, I had to say, well, we do need Viz because we don't have that. And it was incredibly helpful to us to have a tool like Viz. And we also had challenges with neuroradiology because there were concerns that doing more CTs and CTPs in addition to CT head may sort of increase the workload on neuroradiology. And we had also some concerns about whether we had enough scanners to process all the volume. And there were some safety concerns. The kidney issues with IV dye, I think, is now something that people worry less. But one of the things that was very important to me, I wanted to run CT and CTP on every stroke patient and not just the one that were stratified by time or by NIH stroke scale. And so that would indeed have increased the volume by quite a bit. So Viz was the ideal platform to bring everyone to the table and to discuss as to how we want to move forward to improve mostly our time to groin puncture with thrombectomies. As you probably know, Viz is a platform that comes with alerts for suspected large vessel occlusions and ICH. It has a high sensitivity and specificity in the 90s. It comes with advanced mobile imaging viewing system that is really superb. It lets you look at images in all planes and also window it to your satisfaction, not to mention that you can look it up within seconds on your phone. There is a potential to put in real-time patient information and also to look for logs as to at what time, what kind of metric was hit. And lastly, it has a secure communication platform with a group chat function where you can securely and safely share pictures and videos. Viz's workhorse sort of application is definitely the Viz LVO. But it has also other functions that it's working on and already on the market, such as Viz Aneurysm, which is a brand new addition to the platform, as well as Viz ICH, and something that is still in the works and currently only used for research application is Viz subdural hemorrhage. A couple words to Viz Aneurysm. So this is a very exciting features. It auto-detects suspected aneurysms down to above 4 millimeters. And it will give you a list, which you can see on the middle phone. On top, it will say suspected aneurysm. And when you click on that, it will give you a list of all automatically detected aneurysms. It will not ping you, but you can sort of see what all the aneurysms were that came through Viz. And then you can review the images. And if you so wish, you can hit a button on the right bottom corner. It's called Schedule in Clinic. And you can hit that button that will, for example, alert someone, a nurse practitioner or someone in your clinic or in your office to make sure to follow up with this patient. So how does Viz work? It's sort of, you have to think about it as a system of action. So if your regular medical record is a system of record keeping, this is more a system of action. It really is not an imaging platform per se. It's a system that takes all the modalities of the imaging and then analyzes it in a cloud-based fashion, and then predicts sort of time-sensitive disease and connects everyone in the healthcare system in a parallel fashion. Which then results for the patient to be processed through the system faster and have better outcomes as a result. So from the Stratus registry, we know that usual workflow, and this is going to focus on the large vessel occlusion sort of module. It was 202 minutes on average to get from the door to the treatment. And this is also similar in our experience. And with Viz, that time is greatly reduced, mostly because it allows parallel processing. So once Viz, the images get processed, it goes to the cloud. If an LVO alert gets sent out, multiple different teams can be alerted at the same time. So the time savings can be on every single aspect of the hyperacute stroke treatment, whether that's in door in and door out for a referral center, whether that is inside your hospital center for just standard stroke care, or whether that is door to puncture times for your large vessel occlusions. That has been now shown to decrease times in multiple publications. So again, time savings can then also result into improved patient outcomes. In the left lower box, you see improved 5-day NIH stroke scale without Viz, and comparing Viz to before Viz historical retrospective data. There is improvement in discharge modified ranking scale and in 90-day modified ranking scale. There's also reduced length of stay, right upper corner, which can be ICU length of stay or total hospital length of stay. And there's increased access to care, meaning that possibly LVO patients who got undetected before Viz may be now detected due to this inclusion of Viz.ai into your workflow. Now, every healthcare system has their own sort of problems to solve. For us, it was definitely trying to figure out how to improve our thrombectomy times, door to groin puncture. As you know, that's a metric that's collected by the Get With the Guidelines. So we wanted to find a way to provide the right care at the right time with the right providers and also the right cost for the patient. But we were also very interested in keeping the quality up. So we didn't really want something that would replace, the stroke process that we have worked on for so many years and we were good at. We wanted something that would add to it, but not replace it, which I think, it was the big unknown at the time. It's a completely sort of new way of healthcare delivery. So it was important to us that by adding that, we would actually keep our good outcomes. And And, we did also feel very strongly that we wanted to bring the team together. Stroke is such a complex disease, and it spans so many different healthcare providers and departments in the hospital, that it's sometimes, difficult to bring in a very hyperacute situation everyone to the same place at the same time. And so once we have decided that Viz would be the platform that could help us with that, it was for us very important to assess our workflow that we already had in place. For example, one couple of things to think about is how will the pre-arrival stroke code activation affect, implementing Viz. And so here, I think the most important thing to ask yourself is, are you going to be doing CTAs and CTPs on every patient, or are you going to tailor it down to an NIH stroke scale of greater than 6? Or I want to have time be a factor? Are you going to do CTP on everyone after 6 hours or before 6 hours or not? So for me, it was really important that I wanted stroke patients to be treated like trauma patients. And even if they had an NIH stroke scale of 2 and would otherwise not qualify, as long as they were within 24 hours, I wanted them to get a CTA and a CTP. It was that proved to be very helpful in their workflow, because within minutes we were able to know what we were dealing with. And I will give you a couple of examples at the end of this presentation. But as you can imagine, that may not be necessarily the goal of other stroke code providers. In our hospital, we have a private neurology group, and we had to make sure that implementing Viz would be something they would be on board as well, and not feel that Viz is going to overload their current workflow. And so we had to work with them as well. And telestroke is something that a lot of hospitals use at night. We don't use it, but it's important to know how to involve telestroke providers in the Viz process as well. That's something that we potentially going to be looking in the future and are currently exploring. Use of advanced imaging, as I said before, it is sort of highly debatable how you want to do that, but for me, every stroke patient will get a CT and CTP. Neuroradiology coverage, so that is also highly variable. A lot of hospitals will have, a neuroradiology coverage during the day, and maybe they outsource it at night. So it was kind of very important for us to understand as to how the neuroradiologists felt about Viz. And in fact, neuroradiology often have already their own set of technologies that they're using to bump their CAT scans and stroke codes up on their list. And we learned a lot once we started to talk to radiologists as to how they process their stroke code. And then neurointerventional services, for a lot of hospitals, neurointerventional services are not there 24/7, and they don't sit and they may be traveling between different hospitals. Like we are transferring a neurointerventionalist. So for us, knowing when there is a case is extremely important to be prepared and to have a understanding as to how this will impact our other elective cases or where we need to be. But on the flip side, very interestingly, it's almost more important for us to know when it's not a case, because there is a lot of stroke codes, but only about 10% will go on to have an LVO. And the faster we know that, the more we can stratify our workday. Existing technology and apps are now, more and more prevalent. So almost every hospital has some sort of communication app. They have maybe medical records that can be can provide some of the features. They have, certain internet security and other sort of objectives to fulfill. So that was also for us the case. We had just recently gotten an app as to how physicians and nurses can communicate with each other. So then bringing in Viz, it was very important to understand how that will integrate with all these other apps and how to evaluate that a little bit closer. Our workflow before Viz was very sequential. We had the ED physician make an assessment, then we proceeded with a CT head, and then after neurology evaluations, we then catered down who needed a CT and CTP. We had radiology reviewed images, then they had called to the ED physician about the results. And then there was the communication between all these people. And then the neurointerventionalist made the decision to go forward with the procedure if there was a large vessel occlusion. And it just took a long time, honestly. I remember I had to sit and wait until the CTA was completed, and then I had to log into the PAC system, find the study. It was just kind of a little bit clunky and definitely time consuming. So after we had this implemented, the whole process became much more parallel. We changed the process to do CTA, and CTPs at the same time. And then we all evaluated the images at sort of parallel. And if the Viz LVO alert went off, the neurointerventionalist looked at the image, and that was then communicated to back, often through the app, as to whether the team should be activated or not. And so, it took a few kinks in the beginning to sort this all out as to what the best way would be, how other hospitals have done it. And so Viz does provide a customer success specialist, which helps, with the successful adoption of the product, and can also provide some business reviews and some metrics. It can help with case studies. This is not to be confused with support. This is really an extra step. It has been very helpful for us. We wanted to figure out certain things, like how long does it take between CT head and CTA? How long does it take to read? How long, how many people are using it, and all of that. We went back to Viz, and they were able to provide us the report and continue doing so, which is a nice feature. Again, this is basically the same thing I just discussed. And so one of those sort of kinks that we ran into, there was a group of what we called slow adopters. So we had a few people in the beta version sort of testing it, the fast adopters, and then we had to somehow engage the slow adopting users. And Viz was able to provide us a report as to who was not using Viz, who was using it a lot. And based on that, we could, evaluate a process and see what sort of the barriers were as to why some people were slow adopters and others were fast adopters. The other thing with the adoption of Viz, which we didn't do initially, we were then considering, adding additional user groups. And one big additional user group that was added was the entire neurointerventional tech and nurse team. That has dramatically changed my life. Before, I could have been in the OR and some stroke was going on and I wouldn't necessarily know about it. But now whenever there is an LVO alert, literally all our phones go off everywhere and we all know, and immediately a nurse or a tech, is in communication with the ED to see if this patient is coming to intervention. And this really allows us to notify, a secondary neurointerventionalist or just sort of process everything faster. It's really very, very helpful. Again, we made changes to the stroke code process, and we wanted to make sure that we're not hurting patients by doing that. One change that we made, that everyone gets a CT head and a CTA up front. So we wanted to see whether our VTP times were impacted by that. And so we were able to run a report on that and make sure that that wasn't the case. And the other really great feature that we have been using is we have been closing the loop to all our providers, even pre-hospital EMS, by running creating reviews from thrombectomy times and from the log. You can go into Viz and there is a log in terms of, when the patient was, what time metrics the patient was hitting and the communications that happened. And based off that, our stroke coordinator, who is fantastic, it also helps to have a really good stroke coordinator. I was able to create little summaries and feedback sort of emails that we send out, not to all the providers in the hospital, but also to our EMS providers. And as I said before, we do partner with Viz. One thing that we are now exploring is, because we got so good in everything upfront with stroke, we want to now see whether we can improve the stroke care also after thrombectomy, and we're exploring other things with Viz, how to potentially notify EP when there's an AFib patient, etc. I think this is just the beginning of really a great tool for stroke care. Now, a couple of things to analysis post-Viz. Of course, again, as I said, we didn't want to have any quality be impaired as a result of that. So we looked at our sort of clinical metrics, and this is door to activation of the neurointerventional team. We had implemented this in the middle of the pandemic in Q1, which had its real challenges, and compared our data then 12 months before and after. And you can see that we have been improving our door to neurointerventional team activation. And it's really important to us, being a non-teaching hospital and having limited resources, that we don't activate those folks if we don't have to. So we really want to have a high sensitivity of activation, and so they don't have to track into the hospital just to be canceled afterwards. And that has been a real great improvement from that regard. Similar, our door to puncture times improved as well over that time frame. And here are just some data that we looked at. The biggest impact we saw was the door to interventional team activation went from 87 to 63. Now we are down to about 50 minutes. and that followed a door to groin puncture improvement from 154 minutes to 113, and now we are below 100 on average. We didn't see a big difference in discharge MRS, but these are just discharge MRS, and we have a relatively low number. We did see an improvement in ICU length of stay, but not necessarily a total hospital length of stay. Again, we haven't really diced down the numbers as to why that is, but we could definitely see an improvement on door to imaging complete, which was CTA took on average 46 minutes, now it's 26 minutes. And then also we had looked at our new technology add-on payment, which I'm sure you know for CMS cases. You can request reimbursement, which for us turned out to be $819 per claim, and that came with a great saving. Our program grew actually in the middle of 2020 and continues to grow, which is also nice. And now a few case studies. So this is a 59-year-old woman. She arrived from work via our paramedics. She was found to be aphasic with a right upper extremity flaccid. On arrival, we confirmed she was global aphasic, had the left gaze deviation and the right hemiparesis that equaled to an NIH stroke scale of 26. She was last known well 1 hour prior to arrival. She received TPA and was found to have a left internal carotid artery occlusion. And she proceeded to thrombectomy. So here you can see sort of the log, and that's largely taken from the Viz app itself. It greatly improved the quality of life also of the stroke coordinator and data analysts. You can see that when from the CT start to the CTs completed, which is CT head and CTA, it's almost always 6 minutes. And then add on another 5 minutes for the LVO alert. So basically within 19 minutes from door to LVO alerts in this patient. CTA read within 23 minutes. So and here it is important to note that we have our neuroradiologist also provide a reading of the CTA. I'm very particular about that because neurointerventionalists tend to look only for the large vessel occlusion and for the perfusion mismatch. But if there's any other finding, it's very important that our neuroradiologists communicate that to us. They, overread all studies, and they still provide direct communication if there is anything that is out of the ordinary, so we don't oversee anything. And I think that's it's important to me because in the end, it's their report that counts. And even though our work process has been greatly improved, that CT read is an important function in our stroke delivery. You can see the team was activated before the TPA was even given. Patient arrived in the procedural room at 78 minutes, groin puncture 96 minutes, and device in 112 minutes, which is really great for us. And the patient had a TK3 recolonization and did extremely well. Was discharged, I believe, 2 days later. And so here you can see how this played out on the Viz app. The neurologist put in everything, sort of the neurological findings. You can plug it in separately in Viz, but we like to use just the chat function. It works better. And, you know, the neurologists kind of know now what to put in. And you can see the neurosurgeon read it and says activate team. The team will now went to, so that goes out then to everyone that is logged in as on call to the app. We got some more information as to whether the patient got IV TPI or not. And then after the procedure, the neurosurgeon provided some pictures of the procedure. And, you know, we had also some positive reinforcement, which is, I think, very important to not just provide bad feedback, but also good feedback, which really works great with that app and, you know, within minutes of patient arrival to the hospital. Here we have another case. This is an 85-year-old gentleman. He actually was at his primary care office when he had onset of stroke symptoms. He had slurred speech and right-sided weakness while waiting in the waiting room. EMS was activated. He had a right facial droop and then severe expressive aphasia and neglect. His NIH stroke score was 7. Again, he was brought in very early. TPA given, he was found to have a left MCA occlusion, and he also proceeded to thrombectomy with a TQ3 recanalization. As you can see, very similar times, pretty consistent, 6 minutes from CTA to CT completed, 5 minutes later with LVO alert, 3 minutes later CTA read. This was a case where everyone was in the hospital. TPA was given really quickly. He was at 60 minutes in the procedure room, and the device was deployed at 93 minutes. And the following day, he had just a little bit of aphasia, but he was able to communicate, and he was also discharged, I believe, on day 3 after the thrombectomy. And again, you can see sort of the communication that's going on, and some of the pictures from the case, and then the positive reinforcement. Our stroke coordinators like to provide us feedback as well, because sometimes we don't really know how quickly the patient sort of was processed through the system. And, you know, it really comes down now to minutes. Like, I think we were able to have great strides. We made great strides and to get to where we want to be. But now it's shaving off minutes along the way, which is, you know, really hard. And we are currently having a neurointerventional working group within the hospital where we try to improve even upon that. And another case, this is a 61-year-old man. Again, he arrived via paramedics. He was reported to be aphasic and with a right facial droop, an NIH of 7. He was last named well 2.5 hours prior. TPA was given. He had sort of what appeared to be a severe focal narrowing of the left MCA. Here it's sort of important to note that you can sort of customize how you want Viz to alert. So, for example, if you're a stroke physician, you can have just say, alert me whenever there is a CT head done. If you are a sort of interventionist, you can say, alert me on every LVO. And then there's also a feature where you can put in alert me if the Tmax greater than 6 seconds has a certain ml. So you can say, alert me if there is 15 ml of greater than 6 second delay. So that could also capture cases where there is no definite large vessel occlusion, but just a delay in that hemisphere, or even for the posterior circulation. So in this case, actually, the LVO did not go off, but the CTP was delayed on that side, and that gave us a clue that we're dealing with an acute stroke, and again, very similar time. Now here, we communicated over the app, and at the end, sort of the neurosurgeon says, I can't decide if this is intracranial atherosclerotic disease or an embolus, but I got a great result. That, sort of hopefully will illustrate it to you how Viz can be used in real practice. With that, I hope to answer some more questions if you have any, and I hope to find that helpful. Thank you.
Thank you, Dr. Altschul, for that excellent information. Excellent presentation. We have been working here, triaging questions for you. So we'll use the remaining about 15 minutes to get questions answered. So if you have more questions, feel free to add them to the Q&A using your Q&A button at the bottom of your screen. So a few people have asked for the slides, and that has been addressed within the chat. And we will reach out to you with the slides if you need them. Again, everybody's going to receive the video of this presentation. So just starting off, we had a few questions, Dr. Altschul, on what groups in your organization use the app to communicate. Like, are you including nurses? Are you including the neurointerventionalists, the critical care team, the ED team? So who has the ability to use the app and communicate clinical information?
Yeah, so currently we have ED that has access to it, neuroradiology, neurointerventional, neurology, and the stroke coordinator and data analyst, the neurointerventional team, the nurses, and the techs, actually. And we do not have the intensivists on currently, but that is, Viz has a new feature that they're working on, which is Viz Connect. We are currently exploring how we can sort of close the loop and then communicating after the stroke has been performed, if there are any findings such as AFib or even sign out to the intensivist.
Great. I also want to just highlight that we do have in some accounts the emergency medical services also on Viz, and trialing out that as well. Okay, so we can cater it to your needs. Another related question we received is, were there concerns from the ED physicians about the impact of Viz on their workflow, and how did you address those concerns?
Yes. So basically, every single service had concerns about how this would affect their workflow. And ED was one of them. One of the main issues in the ED is communication and being kept in the loop. And not every ED physician is carrying the phone with them all the time. And so they were not really, not everyone was really wanting to be part of yet another app that they have sort of in their pocket. So we do explore with a tablet in the ED. So you can have a centralized tablet where you can sort of go, all the stroke codes come through that and go off. You can have your ED charge nurse to be part of the alert, or if you get all the neurologists on it, then they will communicate with the ED, that there was an LVO alert, because they would be often in the ED. And then lastly, it is really helpful to get all the ED physicians on board, but I cannot say that we were 100% successful to get every single ED physician to communicate on the app. However, it does not seem to impair our workflow too much. And that's because we were very particular that our Viz is not like a replacement to your current stroke flow. It's just really an addition to get sort of bring everything together and make it faster. And it's highly customizable, and you can really cater it to your own sort of needs in your own health system.
Excellent. Thank you. We did get some questions about turnaround time for CTP, and I'll just answer from a company side, and then Dr. Altschul, you can answer from your perspective. Right now, when it's a CTA, we have a metric, 90% of all notifications are seen within 5 minutes. But, a lot of people obviously see that much sooner than 5 minutes. For CTP, because there are bigger files, we have, on average, we are 5 minutes. Sometimes it's a little longer if it's a really big file, but on average for CTP, it's 5 minutes. Dr. Altschul, I don't know if you want to add commentary to that.
Yeah, so that's exactly what we're seeing as well. It's about a 5-minute turnover time to see all the images. And again, from a physician perspective, the most time saving and my quality of life improving feature of Viz is the ability to see the images on the phone anywhere I am. A lot of us cover a lot of hospitals to just log into the PACS system of every single hospital. When you're on call is a huge barrier, but it is extremely important to see the images for us to plan our approach and see, the aortic arch and all the sort of head and neck of cerebral vasculature. So that is sort of the most important improvement in the stroke process. And the fact that it also works for the patient makes it a win-win situation all around.
Excellent. Thank you so much. Okay, next question. Who do you have report out the times in Viz, like door to puncture, door to device, etc.? And do you do this for every case?
Yes. So our stroke coordinator and the data analyst, they go into the log of Viz and they look exactly as to what happened, like who looked at the images at what time, when was it processed as activate the team, when was the CT head done, when was the CTA done. It gives you a metric that you can collect. Now the metrics kind of end at so for example, groin puncture is something that you have to collect separately. That's not something we collect through the Viz app. But often a lot of the information is presented on Viz through people contributing for it, saying IVTP given at this time, or TQ3 was achieved. And so that's what's been used to create these sort of reports. They get disseminated within the hospital and within particularly targeted to every single person, whether it's a nurse, a physician or whoever who was in touch with that patient. But something that, I think as healthcare provider within the hospital, we also have to sort of the opportunity to educate our EMS services and to go outside the hospital. And so that, whether it's communicating with other sort of spokes or whatnot, to send these little sort of feedback notes out has been really tremendous for us. It's very, very appreciated. And I think that's probably what we should be doing on every case.
Thank you. Thank you, Dr. Altschul. Just to speak a little bit to that, remember that Viz has, once it's installed, you have a customer success team, and they work very closely with the hospital. And they do collect data on a periodic time frame where they collect data in aggregate so that you can see some of these metrics in aggregate as well. And so they do help facilitate those analytics. Okay. Okay. So moving on to the next question. We have another interesting question. I am a primary stroke center with telemedicine coverage. We don't have in-house neurointerventionalists. We transfer LVOs to a comprehensive center. How does this work with teleneurology and primary centers?
Yeah, so it depends on what is your goal of care and who is reading the LVO alert. So what you could do is that Viz is, installed on your hub's place, right? And so they would then get the alert that there's a stroke code at your place and then facilitate the transfer. Because really the facility that is going to be receiving the patient will need it the most, and then the ED and the patient, the people that are in a primary stroke center, because you don't want to transfer if it's not an LVO, but because you probably are perfectly fine to take care of that stroke. But at the same time, if it is an LV, you want to be very efficient. I would assume that would be your goal. Now, you can sometimes put certain telemedicine providers have Viz on their phone as well. And Susanna, please correct me, but I think it is a possibility that if they service your hospital, they have access to Viz as well. This could be something that can be looked at with that. Actually, that's a good something for that customer success team. They would be looking at that. Susanna, can you maybe say a couple words to that?
Yes, so Viz has partnered with telespecialists in order to work together and facilitate that, the work that telespecialist does and to use the Viz platform to help communicate with the hospitals. So we are definitely seeing that as an opportunity for this type of center that uses telemedicine. Okay. Thank you for these questions. Okay, next question as we're wrapping up. We only have about 4 minutes left. Dr. Altschul, I understand that you have implemented Viz in 2 different hospitals. One was using Rapid and you switched to Viz, and another one was using AI Doc and you also switched to Viz. And would like to know, in either case, who was a person who was very difficult to convince and that Viz was the better choice, and how do they feel about it now?
That's that's a very good question. I think it's always the person who sort of learns about Viz and gets excited and then brings it back home to their hospital is facing sort of the challenge as to how to get everyone on board. And it's very important, as I walked you through, to kind of address every department's concern. For me, I feel like neuroradiology was probably the hardest to convince, mostly because they had already had a sort of process in place as to how they prioritized their stroke codes, and they already were used to a certain, software that, conveniently showed up in their PACS system, and they didn't really necessarily, they were not necessarily, I think there was a two-way communication issue, as that they were not necessarily in favor of doing CT and CTPs on everyone at that time. So, it took a lot of discussions, and we were able to find a, sort of mutually sort of a plan that worked for both parties. And they're super happy now. I have, not heard a complaint in over a year now, maybe 18 months. In fact, everyone is very happy with it. We all feel that it adds to our day and doesn't distract or take away anything. So that's my story.
Thank you, Dr. Altschul. I just want to add that Viz also has a Viz web. So we are integrated into the workflow, to the neuroradiologist workflow, integrating into PACS. So in order to facilitate that integration. Okay. So I think that we're at time, and I want to thank everybody for attending. And I want to thank Dr. Altschul for sharing her experience. It's been very interesting, not only to see your experience, but those cases at the end really brought it together. And the impact that it's had on your hospital system has also been significant. So we're very happy that you were able to share this. And thank you, everyone, for joining. And please enjoy the rest of your day. Take care.
Thank you.